On to the Pronator Syndrome. Now, this Pronator Syndrome is a compressive neuropathy of the median nerve proximal to the carpal tunnel, usually around the elbow joint. Pronator teres was thought to be an uncommon median nerve entrapment syndrome. However, as more and more trained personnel in hand surgery are being trained, then the pickup rate will increase by you'll be able to detect it much more. There are a few potential compressive sites. These are the supracondylar process, the ligament extruders. You can see the supracondylar process on the X-ray here, and the ligament extruders is a continuation from the supracondylar process. The other potential compressive site includes when the median nerve, travels between the ulnar and humeral head of the pronator teres. And the other compression site is the FDS aponeural arch and the biceps aponeurosis. The continuation is known as the lacertus fibrosis. Investigations. Radiographs may be helpful to look for supracondylar process. MRI may be useful to rule out compression by tumor or hypertrophic muscles. Nerve conduction studies and EMGs are usually inconclusive. Symptoms that may be experienced by the patient include paresthesia in the thumb, index, middle finger, and radial half of the ring finger, as seen in carpal tunnel syndrome. The paresthesias are often made worse during pronation and supination. They may experience aching pain over the proximal volar forearm. There will usually be lack of night symptoms, unlike in the patients with carpal tunnel syndrome. Clinical examination. Positive tinel sign in the proximal anterior forearm. No tinel sign at the wrist. Feelings test is negative. And there are a few provocative tests. This includes the test for pronator teres and the test for the flexor digitorum superficialis, where the long finger is when you resist the contraction, there is a compression at the FDS fibrous arch. And the next is the resisted elbow flexion with forearm supination to detect for compression at the bicipital aponeurosis. Treatment includes conservative treatment, which is rest, splinting, non-steroidal anti-inflammatory drugs for 3 to 6 months for mild to moderate symptoms. And the splint, especially in this type of cases, should avoid forearm rotation. So if you can see in this photograph here, the splint is more proximal to the elbow joint. Surgical treatment includes surgical decompression of median nerve, and this is performed when conservative treatment for 3 to 6 months fails. The decompression of the median nerve should be done at all possible sites of compression. 80% of patients will have relief of symptoms. The take-home message is always check for sensation over the palmar triangle. If the sensation over the palmar triangle is reduced, then you need to perform provocative tests to determine the site of compression of the median nerve. Thank you very much.